Hello, everyone. My name is Dr. Joanne Kurtzberg, and I'm from Duke University Medical Center. I'm going to talk today about our work using cord blood and cord tissue therapies for children with cerebral palsy and autism. The cells I'm going to talk about today are derived from cord blood or cord tissue that has been discarded after birth and can be retrieved and harvested for therapeutic use. Lots of people say that cord blood is a bag of stem cells, but it is not. It's actually a bag of multiple kinds of cells, of which a very small portion are blood stem cells shown in the circle at the top. Those cells can be used to rescue the blood and the immune system after high-dose chemotherapy or radiation for a hematopoietic stem cell transplant. But I am not going to be talking about those cells today. Instead, I'm talking about other cells that are also present in cord blood called monocytes. And monocytes are not stem cells. They do not engraft or stay in the body long-term, but they are capable of modulating inflammation and also inducing formation of new fibers in the brain in certain conditions. In addition to the cells from cord blood, I'm going to tell you a little bit about using cells we manufacture from cord tissue, which are called human cord tissue MSC, or mesenchymal stromal cells. These are also not stem cells, but they are cells that are therapeutic and again, can modulate inflammation and are being tested in multiple types of inflammatory conditions to see if they are active in improving outcomes. On the lower right, you can see a typical bag of cord blood before it is frozen, where it can be stored for decades. MSCs can also be manufactured and frozen and used for dosing in future years. At Duke, we manufacture 3 types of therapeutic cells under GMP. As I mentioned, we collect cord blood, which is donated by moms delivering healthy term babies to our public FDA licensed cord blood bank called the Carolinas Cord Blood Bank at Duke. Those cells can be distributed to patients in need of donors for what used to be called bone marrow transplantation. But in the case of my talk today, we are also using those cord blood units as therapeutic cells, particularly focusing on the monocytes that are in the unit. Again, we also manufacture cord tissue MSCs from umbilical cord itself. Those are manufactured over 3 months in our laboratory. They are then frozen and available for dosing to patients. And these cells can modulate and suppress inflammation. We manufacture a third type of cell called DUOC, which is a cell derived from cord blood monocytes that can help remyelinate the brain, but I'm not going to be talking about that today. So let me start by describing some observations that we made in treating children with cerebral palsy, first with their own cord blood and later with donor cord blood. We got the idea to do this from multiple preclinical experiments in both animals and organotypic or tissue slice models. This slide shows you some work from brain slices that are from mice and can be maintained in culture for over a month. In the left-hand panel, you can see a normal brain slice with green neurons, red oligodendrocytes, and pink astrocytes. In the middle picture, after these cells have been stressed to remove oxygen, which is called oxygen glucose deprivation, you can see that the neurons die and there's scarring, which is represented by an increase in the pink cells or astrocytes. On the right, you can see stressed tissue, but which was then co-cultured with cord blood and with the co-culturing with the cord blood monocytes, the neurons, which are green, survive and do not undergo death. And this was one way we were able to show that the cord blood monocytes could rescue tissue from hypoxic injury. And this and other data that we have that I don't have time to go into today allowed us to provide enough evidence to the FDA to obtain an IND to study the effects of autologous cord blood infusions in children with spastic cerebral palsy. In this study, children who had cerebral palsy, either from birth asphyxia or what's called hypoxic ischemic encephalopathy, or prematurity, or in utero stroke, and whose parents happened to have stored their cord blood when they were born in a private cord blood bank, were treated later on with intravenous infusions of their own cord blood. The study was a randomized, placebo-controlled, blinded design so that all children received treatment sometime during the study, but the order of the treatment was not known. Children were infused at baseline, and again 12 months later. And again, one of those infusions was actual cord blood, and the other was a placebo. And children underwent multiple kinds of testing, including scoring motor function on a test called the GM-FCS scale and the GM-FM66 score. The results of this study were very interesting to us. First of all, the complete randomized group, which are shown in panels A, panel A, placebo being in blue and treated children in red, showed that both groups improved and there was not a statistical significant difference between the two groups. But if you look at panels B and C, you can see that when we divided the children by low dose or high dose being defined as 25 million cells per kilo or greater, the children who received the higher dose, shown in the green bars, had a statistically significant improvement in motor function compared to children getting low dose or getting placebo, low dose in red and placebo in blue. This was confirmed in panel D on another test of motor function called the Peabody motor scale. Of interest, we found that this increase in motor function was accompanied by, on whole brain connectivity, shown on the lower right, increases in the motor tracts and the nodes between the motor tracts in the children who got the higher dose of cord blood and who had improved motor function. So from this, we concluded that cell dose was important and that it appeared that the cord blood cells, probably the monocytes, were stimulating the formation of new tracts in the brain. We took this another step and followed on with a study we called Accent CP, where we tested infusions of donor cord blood, which we used to get to a higher cell dose of 100 million cells per kilo, or cord tissue MSCs. And this was a randomized but not blinded study where one arm of the study, the children received a single dose of high dose donor cord blood. In the middle arm of the study, children received 3 doses of cord tissue MSCs. And in the final arm, children were observed for a year as a natural history arm, and they got a cord blood infusion at the end of that year. The study was designed to ask whether high-dose allogeneic cord blood would duplicate the results we saw in the autologous cord blood study and improve motor function on the GM-FM66 scale, and also whether MSCs would have a similar or greater or lesser effect. Bottom line for this study, we found that cord blood, but not cord tissue MSCs, improve motor function in children with CP. And that's shown in this chart here, where the p-value for the change in motor function in the cord blood arm was 0.017, but the p-value in the MSC arm was not statistically significant. And we concluded from this study that the dose of cord blood cells administered correlates with response, that the minimum dose we observed in our first trial of 25 million cells per kilo is valid, but that a dose of 100 million cells per kilo is more effective, and that we can only achieve that high a dose with unrelated donor banked cord blood units. So sometimes a picture is worth 1,000 words. I'll just show you that the child in the upper panel is shown at study entry, where he can't walk independently, he scissors, he's wearing braces. And in the lower panel, a year later, he is able to walk independently, and he has better balance and doesn't require the walker or the braces. Now, you have to remember that when you're doing studies in children, they change over time because they are growing and developing. So the burden is on people like us who study these kinds of interventions, is to prove that the intervention improved function in the child more than that child's normal development would have done. And this is an illustration of a meaningful improvement or a meaningful clinical change in a child who would not have been expected to make that much progress in a year. Now I'm going to turn to our studies in children with autism spectrum disorder, first talking about cord blood. We conducted and published the results of a phase 1 trial testing whether autologous or the child's own cord blood intravenous infusions were safe and feasible in young children with autism. And all of the studies in autism were conducted with my colleague, Geraldine Dawson, who runs the Center for Autism and Brain Diseases at Duke. In this study, 25 children with autism ages 2 to 6 years received a single infusion of autologous cord blood, which was dosed between 10 and 50 million cells per kilo, because this study was performed at a concomitant time of our first CP study, and we didn't know at that point dose was important. Children were assessed at 6 and 12 months for feasibility, safety, and efficacy. But we recognized this was an open label phase 1 trial, so the efficacy results are purely descriptive. We wanted to use this study to determine feasibility and endpoints for a larger phase 2 randomized trial. You can see on the right that in this trial, we defined the Vineland socialization scale as the primary endpoint, and children did improve at 6 months, and the improvement was sustained at 12 months. And that enabled us in our subsequent trial to use a 6-month endpoint. In addition, on the bottom panel, when we divided the children by intellectual disability or not, as defined by a nonverbal IQ below 70 in the blue bars or greater than 70 in the red bars, the children with nonverbal IQs in the non-disabled age had more of improvement after cord blood infusion than the children with intellectual disability. In this trial, we also looked at several other endpoints to consider for a randomized phase 2 trial. And at the end of the day, we saw that eye tracking did correlate with the Vineland response, and that we felt that the use of eye tracking, EEG, the CGI, and the PDDBI would be useful to take into phase 2 trials. These studies are published, so I'm going through them kind of quickly. We also collected biomarker samples, which were stored for future testing. We then went on to conduct a phase 2 randomized clinical trial of the safety and efficacy of intravenous cord blood infusions for treatment of children with autism. And this study was published in the Journal of Pediatrics last year, and it included 180 children ages 2 to 7 years with autism who went on to the trial with the design that is illustrated here. So the child was evaluated for eligibility. A cord blood unit, either their own or an unrelated donor cord blood unit, was identified and evaluated. The child then came to Duke, had a clinical in-person evaluation, and was randomized. It was a 2-to-1 randomization between placebo or treatment with cord blood, and the cord blood group was divided between children who received autologous or their own cells, or children that received donor cells. And by this time, we knew that dose was important, so the minimum dose allotted was 25 million cells per kilo. 6 months later, the children came back for a variety of assessments and then crossed over and received either cord blood or placebo based on what they had randomized to. So essentially, this was a blinded trial where all children received study product, but the order of the infusions were blinded to not only the children and their families, but to all of the assessors. And there was no assessment of response after 6 months. So the assessment was really performed related to the first dose that the child received. All children were followed up for 12 months for safety. The safety outcomes were good. There were no significant severe adverse events observed during the study. There were infusion reactions that occurred in both the placebo group, the autologous cord blood group, and the allogeneic cord blood group in equal frequencies. None were serious and all resolved with additional treatment with Benadryl or a breathing treatment with albuterol or a second dose of Solumedrol. And we believe those reactions were due to DMSO, which is a cryoprotectant that is used to freeze cells and was also present in the placebo. Many parents did report mild and transient anxiety or other psychiatric symptoms in their children post-infusion. These were short-term and self-limited. They occurred equally between the placebo, autologous, and allogeneic cord blood groups, but they occurred in a significant number of children. And we believe that they were due to the disruption the study created by requiring the children to travel to North Carolina, to stay here for several days, to have an infusion in the hospital, and to have all the testing associated with the study. Now, for baseline characteristics, we intended to enroll at least 143 of the 180 children with children who had normal cognitive function. That meant nonverbal IQ greater than 70. But we relied on remote testing to assess IQ, and we didn't turn any children away once they had come to Duke to be enrolled on the study. And at the end of the day, we only enrolled 101 children with a nonverbal IQ greater than 70, which reduced or underpowered our study to answer its basic question. There also was an imbalance in the distribution of children with higher function between the autologous and allogeneic cord blood cohorts, with the allogeneic group having fewer children with without intellectual disability. Finally, the children treated with the allogeneic cord blood received a significantly higher cell dose than children receiving autologous cord blood. Although they were both above 25 million cells per kilo, the allogeneic group received an average of 38 million cells per kilo versus 27 million in the autologous group. And as a result, we really couldn't distinguish cell source differences from dose differences. This shows you that data in a chart, again, points out in green that there were lower numbers of children in the allogeneic group without intellectual disability, and that there was a higher cell dose in the allogeneic group as compared to the autologous group. Now, we didn't achieve our primary endpoint in this study. The primary endpoint was mean change in the Vineland-3 socialization score at 6 months. As you can see on the left panel, where blue is placebo, red is autologous cord blood, and green is allogeneic cord blood, the recipients of the products did not have a statistically significant response. And in fact, the placebo response was quite high and higher than we anticipated. Now, the graph on the left is divided between the children with a nonverbal IQ less than 70 and nonverbal IQ greater than or equal to 70 on the right. And the distinction between the higher IQ children is a little bit more prominent, but neither were statistically significant. When we subsetted a group ages 4 to 7 with nonverbal IQ greater than 70, then we did see a trend towards response in both the autologous and the allogeneic group. We also looked at changes in the Vineland-3 Communication Score at 6 months. And again, in the entire group divided by nonverbal IQ less than 70 or nonverbal IQ greater than 70, we saw a huge placebo effect in the lower functioning children, but we saw a statistically significant response in the higher functioning children. When again, we subsetted the kids ages 4 to 7 with no intellectual disability, we saw a statistically significant response in both cord blood groups. In the CGI, which is a clinician-rated, interview-based behavioral outcomes test, we did not see an effect of autologous cord blood as compared to placebo. But in these two lower bars, in the children without intellectual disability, we did see an effect of the allogeneic cord blood when compared either to the autologous cohort or to the placebo cohort. But again, I have to remind you, we can't distinguish that allogeneic observation from a cell dose observation because that group got a higher cell dose. And then in eye tracking, we did see, again, in the children with nonverbal IQs greater than 70, shown in all of the right-hand panels, that there was improvement in executive function and ability to attend or pay attention to the video, particularly to the toys in the video, in the children who got cord blood. And in EEG, we're able to see that there was increase in alpha and beta spectral power in the children treated with cord blood in the red circles compared to children treated with placebo, shown in the blue circle. So the conclusions of this study were that our primary analysis of the whole study population did not show a benefit of cord blood over placebo on the Vineland-3 socialization scale. However, the study was flawed because we ended up being underpowered because we didn't achieve our goal of 143 children without intellectual disability. For children with no intellectual disability, again defined as nonverbal IQ greater than or equal to 70, we did see improvements in communication on the Vineland Communication Scale, attention through eye tracking, and increased alpha and beta EEG power. And children receiving allogeneic cord blood, which again was higher dosed, did show improvement on the CGI improvement scale compared to placebo. Notably, the high expectancy effect in the placebo arm and the larger number of participants with intellectual disability compromised the interpretation of the results of the study. And the MRI data analysis is still ongoing. So the lessons we learned from this study is one, that the placebo effect is higher than predicted in the parent-reported outcomes on the Vineland, that remote measurement of IQ was not reliable for children, particularly under 4 years of age, and that the response in lower functioning children is challenging to measure with currently available outcome measures. Solutions we're applying to the design of our next trials are, one, restricting eligibility to children 4 to 7 years with a full scale IQ over 70. We will predetermine IQ prior to study enrollment. We refine the primary endpoint to the mean of the socialization and communication scales on the Vineland-3. We confirm the definite need for a concomitant placebo control arm. And we're increasing sample size to account for the larger placebo effect. So I'm going to end telling you a little bit about our studies in children with autism with allogeneic cord tissue MSCs. These cells are made, again, from donated cord blood after maternal consent, who also donate the cord tissue from healthy term male babies delivered by C-section, and that's so we can keep the tissue sterile. We digest the tissue, we grow and expand it in tissue culture out to what's called passage 2, where it's then cryopreserved in bags that can be used for dosing. It's completely tested for characterization, sterility, endotoxin, viral pathogens, and it's characterized both by phenotype and potency, which includes suppression of a third-party lymphocyte proliferation test and suppression of microglial activation. So the suppression of microglial activation is shown in this slide, where again, in a brain slice organotypic model, on the upper 3 panels shown in green, on the left, you have normal microglia stained with CD68. In the middle, you have activated microglia after exposure to a toxin called LPC. And on the left, you have activated microglia co-cultured with the cord tissue MSCs to show that the activation can be suppressed. And visually, you can see that by return of the processes shown in these cells. But on the right, you can see that we digitalized this assay so that we could quantitate it. And we require that the MSC line that we take into the clinic suppresses microglial activation by 70% or more. We performed a phase 1 study, which also was published a few months ago, looking at 1, 2, or 3 doses of cord tissue MSCs at a dose of 2 million cells per kilogram per dose over a 4-month period in 12 children with autism, and they ranged in age from 2 to 11 years. These patients got 27 cumulative doses, and the 3 dosing cohorts each got exposed to 3 donors. We didn't see any difference in the donors or the doses as far as safety was concerned. We did make one observation, though, that is important and that we are following and is shown on the lower right graphs, and that is that half the children did develop low titer anti-HLA antibodies against the MSC donor. These were not clinically significant, but they were there, and we are following that finding in our future MSC studies. We also observed, and again, this was an open label study without a randomization or a placebo arm, that 58% of the patients improved in at least 2 of the 3 outcomes we measured on this study. And that included the Vineland Socialization Scale, the PDDBI, or the CGI. And that's shown in this graph. So with this data, we've now embarked on a study we're calling Impact ASD. It's a randomized, blinded, placebo-controlled phase 2 study testing cord tissue MSCs in children with autism. This study will have 164 to 300 subjects, and the final size will be determined by an interim analysis. The children can be 4 to 11 years in age. They have to have a full-scale IQ tested on site of greater than or equal to 70. And they will be treated with 6 million cells per kilo of MSCs given as a single IV dose. So you can see the study design. The children are randomized to either placebo or MSCs. They are followed for 6 months, come back, cross over, and get treated with whatever they didn't get the first time. So the placebo children get MSCs and the MSC children get placebo. This is all blinded, so no one knows the order of the infusion. The primary endpoint of the study is the mean of the change of the Vineland-3 socialization plus communication scales, and the secondary endpoints are eye tracking, EEG, CGI, and PDD-BI. And this study is currently accruing patients. It had a hiatus because of COVID, but it is now actively recruiting. And I just want to point out that the primary endpoint for this study is based on the data from the Duke ACT study. And this shows you from the Duke ACT cord blood study that if we use the mean of the Vineland-3 socialization plus communication scales, it will be possible to detect an effect of cord blood if it exists with MSCs. So in conclusion, we've conducted studies of safety and preliminary efficacy of cord blood and cord tissue MSCs in children with cerebral palsy and autism. Administration of both cell sources intravenously are safe. Cord blood improves gross motor function in children with CP in a dose-dependent fashion. A minimum of cell dose of 25 million cells per kilo has been established. But MSCs do not improve function in children with CP. And I'll just point out that the injury in CP is static, and there is not really a component of inflammation at the time we're treating these children, which is 2 to 6 years post-injury. In autism, cord blood appears to improve communication on the Vineland and executive functioning shown on the eye tracking, but further and better designed studies are needed for confirmation of these observations. Cord tissue MSCs have the advantage of providing multiple doses from a single donor, are safe, and are currently being tested in a randomized placebo-controlled phase 2 study in children with autism. So I want to thank you for your attention. I'm happy to answer questions remotely, but I have to acknowledge that these studies would not have been possible without a large collaborative study team led by myself and Dr. Geraldine Dawson from the Center for Autism and Brain Diseases at Duke. Jessica Sun was a co-PI on the studies I presented. And Alan Song did the MRI work for whole brain connectivity. Our Duke Stem Cell Laboratory, Carolina's Cord Blood Bank, and our Robertson GMP Cell Manufacturing Laboratory manufactured the cells that were used in these trials. Jesse Troy is our statistician, Amanda Parrish, the head of our regulatory group. But really, it took a village to get these studies done. And I also have to make you aware of the fact that these studies would not have been possible without the support of the Marcus Foundation for the studies in autism and the Robertson Foundation for the studies in cerebral palsy. And without their support, none of this work could have been done. So I thank you very, very much. And again, I'm happy to answer questions remotely.